on the Dr. Salon coming up on March 20th.
No.
I have a tentative surgery date for you.
Then it was you that
Well, not me, Candace.
right, because I told her that I had to wait to talk to all of you. We mentioned something about it, and I was actually going to call back to see who was the one that scheduled it, so I'm glad we're here today. I can't because I'm in the process of moving and we have to get moved in. So I talked to Dr. Brown, and she said the next available, depending on who I choose, is either April 10th or April 15th.
Okay. Well, okay.
Yes, so let's cancel that one because I haven't even made a decision yet.
Okay. All right. Have we made a decision if we're doing one breast or two breasts?
I mean, I can't imagine just getting one.
Yeah.
Do you? I mean, I don't know. This is all new to me.
Did she talk about a lumpectomy versus a total mastectomy?
Yes, but, you know, like when I left her, sorry, I was totally like, yep, double mastectomy. I'm not going through all that other stuff. And then when I went to go see the radiologist, then I wasn't so sure.
Right.
So then we'll meet today. I have the oncologist tomorrow. So.
Where you'll be making all of your decisions.
Sorry?
Where you'll be making all of your
Yes.
decisions. Got it.
Probably by the weekend.
Okay.
Because why wait?
Why wait?
And I was kind of trying to plan it because of like spring break. Like I would work up until spring break, have that time to get the house ready, and then go in for surgery.
Okay.
So it was just ideal.
So everything's still kind of up in the air.
Yes.
What size bra do you currently wear?
34C.
Are you happy with your size?
Hmm?
If we could make it the same at the end of the road, would you be happy with that?
Yep.
Okay. All right, I'm going to go grab Dr. Salon. He's going to come in and say hi, and then he'll step out, and then we'll change, and we'll come back and do an exam, okay? He wants to say hi before you just start taking your clothes off. And if you need help, I will help you. Okay.
That's my part too. Okay, great.
That's what I'm here for.
Thank you.
You're welcome.
It's exhausting just getting dressed and undressed.
I know.
Okay, I'm going to pause.
Hi. Elaine.
Elaine, you holding up okay? I know. Liz just told me about about 1,000,001 things that have hit you all at once.
Mm-hmm.
So, including the hand, which obviously no fun at all for anyone.
Didn't know. Like, just on my knuckle right here.
Yeah.
Tiny little spot. And it came,
Did you have Mohs surgery for that?
yeah.
Oh, who was that with?
Dr. Chang.
Oh yeah, he's a nice guy.
Yeah. But I guess there's not a lot of skin
Right.
and tissue,
Right.
and they were afraid, so I guess they grafted it, flapped it. I don't know.
They sent you to a plastic surgeon, or he did it?
He did it.
Yeah, no, that's okay.
Oh, look.
Yeah, he's very, very, very capable of that.
It looks terrible.
Well, you'll be shocked how with some healing,
That's what they said.
It will. I mean, obviously, I'm not looking at it, but it's normal for it to not look good in the beginning.
Okay.
So don't be freaked by that.
Okay.
You'll see with some time how that will change.
But it's just so, you never think about it. And it's worse because you just can't squeeze anything. So opening pill bottles, opening up, like,
Yeah.
just anything.
Yeah, it's very,
Typing, can't do
totally
it.
Very debilitating, I guess.
And I'm moving in the meantime, so yeah.
Isn't it?
And then I have all my appointments this week to decide what I want to do.
I know. You want
So-
to add anything else to that?
Sure, bring it on. What doesn't kill you makes you stronger, right?
Look, if I have to find a silver lining, I think it's so important that you have a little bit of a sense of humor about it, because
Have to,
I know.
or else I'll lose it.
You don't. You'd be surprised. A lot of people don't, and they have a much tougher go of things.
I think positivity is half the battle right there.
Couldn't agree with you more.
Absolutely.
And trying to be as objective as I can, I will tell you that people who maintain some positivity seem to do better. Better recoveries, fewer risk of issues. May sound bizarre, but I've been doing this 10 years, and I really feel like that's true.
And with all the hell that I'm going through, I think my diagnosis, the four, like, I forgot what it is, but the size, the stage,
Confidence?
the
Great.
grade, and whatever the fourth one is the best it could be. So I have to keep thinking about that.
And what Liz kind of mentioned to me, I know Liz, the left is your problem child.
Liz.
Liz is the MA that you just spoke to.
Oh, okay, I'm
Yeah,
sorry. I
that's
was
okay.
thinking it was Dr. Brown. Okay,
No,
sorry.
But
Go ahead.
She mentioned the left is your problem child,
Yes.
and that you're still kind of a little undecided on
Mm-hmm.
doing a lumpectomy versus a mastectomy.
Right.
Okay. So
Talked to the radiologist
Perfect.
last week.
Yeah.
I'll be honest. So when I talked to Dr. Brown,
Yeah.
I was like, nope, I'm getting a mastectomy. I'm not going to go through this ever again.
Sure.
But then I talked to the radiologist,
Mhm.
and then I was on the fence.
So everyone's.
So-
I know it's a lot to take in, but I think it is really important to hear from multiple people because everyone's going to have their own different perspectives.
Right.
And my perspective is not going to be really on the cancer, but on the aftermath.
Right.
Right. So let's talk a little bit about each and what my role would be in it.
Okay.
My role, whatever it is that you choose, is completely optional. Right?
Okay.
You can have just a lumpectomy and heal well. You may have a breast that's kind of deformed, that has an area that's hollow and looks funny, but theoretically you could live a totally normal life like that, right?
Okay.
So if you want me involved, it's something that's really your decision, and nobody should be pressuring you for that. You shouldn't feel any pressure from my staff, from Dr. Brown, from whomever.
Right.
Same with a mastectomy. You could just remove the entire breast, have a flat chest, and call it a day.
I heard that's the thing.
I wouldn't say that's the thing. I think maybe 10% of people choose that. And maybe that's different from 5 years or 10 years ago where it was 5% of people.
Okay.
You know, so
Well, I'm not looking into that.
well,
So
there you go. So there's our answer.
Yeah.
I'm
Why-
52 and single and still young, and yep, not
Yeah.
doing that.
So
Why
that-
would
that's-
anybody choose that though?
Most of the time it's older patients, so women who are 75 and up, and they
right.
say,
Married
hey,
and-
Married, they
understand.
don't care.
yeah, Mary, I don't care. My husband can barely see, so yeah,
So
I mean,
why
I'm
would I
joking
go
around, yeah.
through that?
Right, but honestly, that's how a lot of people think. So, and it's really up to the individual. Or
Yeah.
a lot of women are widows and they say, hey, I'm not sexually active. I just want to keep it as simple as humanly possible. Okay, well, we do that.
Oh, that I could stand for older people.
Yeah.
That's just not for younger.
Okay,
it's
let's-
pretty rare that for a younger woman to want to do that.
Yeah.
Yeah.
Okay, staying on
Uh,
track because I'm
so-
not getting that done.
So lumpectomy
Mhm.
obviously means portion of the breast is removed.
Right.
Again, if you just do that, there will be kind of a concavity, a hollow, a divot, if you will.
Okay.
So my role in that would be we can do a technique that's sort of adapted from cosmetic breast surgery. We're basically doing a breast lift. We're rearranging the remaining breast tissue to fill that hollowness and make the breast perkier. It does.
To go along with this one.
Now, we of course operate on both sides.
Okay.
Yeah.
Oh,
So we do the cancer side, we do that first,
okay.
meaning all in one surgery, but we operate on that first, and then obviously while you're still asleep, we see what we needed to do on this side, and then operate on the other side to match it.
And I'm laying on my back.
We do a number of measurements and markings before surgery.
I'm like, that won't
And
tell you the
bed, and the
truth.
bed sits up.
Okay, got it.
So it's
Okay.
not just your whole flat the whole time.
Okay.
The pluses of that are pretty easy recovery, not bad. One surgery, all done together. Obviously, Dr. Brown and I are there together. She's doing the lumpectomy, and then I'm doing the lift. The downsides are
Well, so oh, okay. Where's the part where I would have to get this? Sorry.
it's okay.
This wouldn't be after the radiation?
No, the lumpectomy is done before the radiation.
Well, I know that.
Yeah.
But isn't that hollow space going to be caused by the insert that goes in?
No, it's by Dr. Brown has to actually remove a chunk of tissue.
Okay.
Usually about
If
the
it's
size-
5 millimeters, and I know she wants to get a great margin,
It'll-
what are we looking at?
size of a tangerine, typically. It's more than you think.
Okay.
Because you can't number one, it's difficult to say, oh, that little P, that's exactly where it is. So I'm going to just cut out that tiny little thing. You kind of say, and there are these special instruments say, okay, we know it's in this area, but it's not a pin. In other words, that we can just sort of say it's exactly in this one spot.
And you want to make sure all margins are clean because you don't want to go
So
back
you
in.
say it's in this area, and then there's a margin around it you want to take. So it ends up being a decent size of tissue, even if it's a 5 millimeter tumor.
Okay.
So then you're talking about if it's a lumpectomy, you go in there and do what you
Fill
have
in the
to
missing
do,
spot.
even if it's a lumpectomy.
Correct.
And both sides.
You have to be okay with the breasts being smaller because obviously some breast tissue is getting taken out. Whatever's taken out from the cancer side, we obviously try to do something similar on the non-cancer side to make it match. And we're tightening the skin, which has a bit of a reducing effect on the size of the breast as well. So generally speaking, you go down at least a cup size.
At least a cup.
Depends again on a lot of things. When I take a look at you, I can give you a better idea.
Okay.
But it's usually at least a cup size. You know, sometimes a cup and a half, not usually a whole lot more. Unless some people want to be a lot smaller. You know, some people come in with.
No, I think I'm the perfect size.
Okay. So you kind of have to embrace the idea of being a little smaller than you are now if we go down that route.
Okay.
The radiation, obviously, you would get just on your left side after you've healed. So usually about 4 to 6 weeks later.
So, healing from the lumpectomy.
Where it's all one surgery.
Yep.
Lumpectomy.
How long does that take to recover?
You'd be back to a lot of normal life activity within about 2 weeks.
Oh,
It's not a bad recovery.
but then I have to wait.
And a little longer for the skin to fully heal.
Just get
So
6
usually
weeks.
waiting at least 4 to 6 weeks before you start the radiation.
Yeah, he did tell you that.
Okay. Well, I've had a lot of information in my head.
Yeah.
So I would literally just have to be off from the date of the surgery.
Most people end up taking several months off.
Yes, because I can't go back for 2 weeks because if you go on FMLA, you just have to go through the solid.
Exactly. Get it. And that's why I say most people just end up taking 3 months off.
Yeah, because that would be
That's what the
6
lumpectomy.
weeks. Yeah.
Because of the radiation.
Yeah, because like
Okay.
2 weeks to heal, but I can't go back for 4 weeks
Now, if you're
after. So that's 6 weeks
now,
right
if
there.
you're lucky, they may say, hey, guess what? Your radiation slot's going to be at 8:45 in the morning. Well, then you could go to work after your radiation if you want to.
No.
Okay.
No.
No,
No,
just
no, no.
asking. Just
No,
throwing it out
I'm
there.
not excited to go back to work. I got
There-
this.
There's your answer. So that's one option. The radiation can create some degree of asymmetry. Some people will respond differently to the radiation. Some people, the breast will shrink a little bit more with the radiation. Some people, I can't even tell which breast got the radiation. It's almost impossible.
What
to
does
tell.
radiation do to your body?
The bad joke in plastic surgery is radiation is the gift that keeps on giving, right? And it basically is like an internal, from the inside out, a burn. It damages the tissue. Now, obviously, that's done to prevent or reduce the risk of the tumor or cancer growing back, but it definitely has an effect on the surrounding tissue. It's not going to affect, unless there's something that I don't know about you and they said anything different, going to affect the deeper structures like your lung or heart, but it will for sure permanently affect the tissue of your breast and the skin of the breast. So if you say, I had the lumpectomy, I did the lift, I got the radiation, there's this asymmetry now that I'm not crazy about. We're really handcuffed in how much we can do. Once this breast has gotten radiated, it's extraordinarily delicate and difficult to operate on again. It just doesn't heal normally. So the things we can do, the options we have going in the future are very, very limited.
Limited.
So you have to be kind of okay with that.
Okay.
Plastic surgeons in general, and please realize I'm heavily biased, aren't crazy about radiation in general because of that. And I think it's a really important thing that may not be discussed enough is the long-term impacts of radiation.
And that's what I forgot to ask him about. And
that in your breast will be permanently changed for the rest of your life if it's gotten radiation. It will never be
Well,
normal.
it'll be permanently changed if I got a reconstruction.
Yeah.
Right?
But
So-
you'll have a lot more options. Not that it's
Okay.
necessarily the right choice, but
Absolutely. I know,
the
but this is what you do for a living.
Yeah.
Just like he probably didn't tell me the long-term effects because whatever.
Yeah.
So, okay.
So mastectomy,
Yeah, let's just talk that.
best analogy I can think of is think of a mastectomy like taking a pillow out of a pillowcase. Okay? The pillow is the breast tissue. The pillowcase is the skin of the breast.
Oh, okay, that's a good analogy.
So now our job is thinking, how do we refill that space? How do we replace the pillow? We really have two options, but before I get into that, most of the time, but not always, and this is where it gets into the weeds, breast reconstruction after a mastectomy is a two-part process, meaning two separate surgeries. Okay? The first surgery, so Dr. Brown and I would be there together. She would do the mastectomy, and I would place this. This is a tissue
Spacer.
expander.
Oh, expander.
Spacer,
Expander.
very commonly used. It's got this little valve on it here, so it would go under the skin. After surgery, we could place a needle through the skin that you barely feel and gradually inflate it to stretch the skin to the size that we want. The advantage of this is you really get to be in the driver's seat of how big or how small you want to be. So if you said to me, I'm the perfect size, well, then we would try to get you back to where you are. If you said, hey, I actually want to be a little bigger, or hey, I want to be a little smaller, this gives you all total control.
Okay.
This typically stays in place for at least 3 months.
So from the mastectomy. Okay. So
So 3 months later is when we're at the soonest we're thinking about our second surgery.
okay. So that takes me up to July, right?
And again, I'm using the word at least. Sometimes it could be long, could be 4 or 5 months. Sometimes in certain situations, God forbid, you need chemotherapy or radiation, which we don't anticipate.
Right.
But on rare occasion, there are surprises. We'd have to change that timeline, and you might have these in for longer.
Are they uncomfortable? Can I feel them?
Most people do well with them. Some people do feel like you can see it's got these little tabs, almost like, oh, in certain positions it digs in a little bit.
Okay.
Usually pretty well tolerated, though, in general. Regardless, when we're talking about the second surgery, that's where we have an important decision to make, which is we know this expander is temporary, this is coming out, so what do we use to finish the reconstruction? One option and the more common choice is an implant, a silicone implant. These come in many shapes and sizes, designed to kind of emulate how a breast feels, but will always feel foreign and different to a
Aren't
certain
those the ones that could possibly leak?
These are what we call gummy bear implants. We don't use those style implants anymore in the United States, or very few people do, I should say that.
Right.
So if I took a knife, made a big gash, squeezed it as hard as I could, nothing would leak out and hit the floor. Like a gummy bear, I could cut the whole thing in half, and the inner material stays within its shell.
Okay.
So
That makes
it's
sense.
leak-proof.
Okay.
The other choice is what we call a flap, which means we're taking skin and fat, usually from the lower tummy, and actually transplanting it up to the breast. Much bigger surgery. Surgery's about 8
You
hours.
take it out and put it in, or you tunnel it?
No, take it out,
Okay.
completely disconnect it, put it into the breast, reconnect little blood vessels to give it life. Really is like a transplant. Like instead of you getting a kidney from someone else, you're giving yourself a breast transplant. Except you're taking it from your own body, right?
Pros and cons?
Much bigger surgery, bigger recovery, 8-hour surgery, a couple days in the hospital, longer recovery, but it's your own natural tissue. It grows with you. You gain weight, they get a little bigger, and it's the closest you'll ever be to having your natural breasts back. Sensations better, satisfaction with the reconstruction tends to be a little bit.
I'll actually have sensation?
You're more likely to have, it's not a zero-sum game. It's not an all or nothing.
Don't they take my nipple?
We have to see. Let me see.
Oh, okay.
But
Sorry, I'm
we
skipping.
may, let me see where you're starting from. If the nipple's kind of low now, then usually we need to remove it. If it's not, then we may be able to save it.
Mm-mm.
See?
No,
Go.
I
Don't
have
necessarily-
very dense breast.
Okay.
So for a 52-year-old, I think I have.
Good. Unless the tumor's really close to your nipple, which I
That I
didn't,
don't know.
I didn't see that in your report, but I'd have to dig a little more.
Okay.
So we can kind of come back to that if,
Okay.
if you are a good candidate to preserve the nipple. So flaps, so sensation, no one has a completely numb breast, and very rarely do people feel the breast totally normal, right? So those are the two extremes. Almost everyone's in the middle. Generally speaking, patients who get the flap tend to have more sensation than the ones who have an implant. That's the best.
What about
way.
insurance?
This is all covered by federal law.
Okay.
So don't even let that
Okay.
factor in. Okay.
Well, I have Centera, and it's not always the best.
Yeah, we
Okay.
haven't had issues, if that makes you feel better.
Okay.
The implant surgery is obviously a quicker recovery, easier, has some of the downsides we mentioned, and because you're young, you may need further surgery in the future. These will not last forever. You don't have to change them every 10 years. Some people still say that. But 15, 20 years, you may need further surgery to change them.
Okay.
So we don't need to make the decision now. Again, I'm just giving you a little background so you have an idea of how this works. But most likely expand it first.
Well, I understand why this is more invasive because you're actually taking the tissue and moving it instead of not taking tissue and just plopping that in.
Exactly.
What kind of scars would I?
This is where it gets into the weeds. There's a lot of different ways we do this surgery depending on your anatomy, how much extra skin you have. But usually it's a long scar, like a tummy tuck. I don't know if you had and know any friends who've had one. It's a tummy tuck scar, typically goes from hip to hip, kind of across the lower portion of your belly. So you can usually hide it pretty well in underwear or a bathing suit. But again, kind of depends on how much loose skin you have and your starting point.
Yeah.
You never saw my scar?
No.
I had
You had the tunneling, didn't
Yeah.
you? Where
I
they
had the tunneling.
tunnel it?
Just
up?
on the one
tram
side.
flap. Yeah. Mm-hmm.
Yeah, and I do it. I don't even know if you can see it anymore, but it was one, from there to there. And I do have to say that the mastectomy was a piece of cake. The reconstruction, not so much.
You had a big surgery. When the tunneling was done, they were also taking part of your six-pack muscle. We don't do it that way anymore. Obviously, the techniques have changed. So now we're taking just skin and fat. We're not taking out the muscle. For a lot of reasons. Pain, destabilizing people's core muscles. We really obviously try to avoid that now. So it's a different operation now. It's pretty different.
Okay.
In a good way.
So let me ask you this. My biggest fear is it coming back somewhere else. I mean, if my body produced this type of cancer,
Yeah.
I know it won't come back in that spot because I would have the radiation, but it could come back over here.
Look,
How?
if that's your biggest fear, this is black and white. Then the answer is a mastectomy, right? Because the mastectomy is going to give you your lowest possible risk of having a new
He said it
cancer.
was the same though.
Your survival is the same, but your risk of recurrence is lower with a mastectomy, and no question. That's undeniable. If that's what he said, he's mistaken. I think he probably was trying to miscommunicate.
I
No,
think he was
I-
talking about that specific area, maybe.
Maybe just that area.
Yeah, I
That's
don't
possible.
know. It was
Yeah.
kind of.
Generally speaking, and obviously there's so many caveats, the risk of someone who has a cancer getting a lumpectomy and later developing a new cancer is in the ballpark of 10 to 15%.
That's too high.
Then there's your answer. I think, and obviously I don't want to make it so cut and dry, but if that's not okay with you, then don't do a lumpectomy.
But you can still, even though you have the mastectomies,
The
you
mastectomy,
can still get cancer any other place in your body. I mean,
absolutely.
it doesn't guarantee that you're not going to get it someplace else.
Well, of
I mean,
course.
you can't live.
But there are
your
different
life-
types of cancer.
Yeah.
The mastectomy doesn't make it 0%, but makes it extremely unlikely that
Because
you'll
there's
develop-
very little live tissue left.
You got it. Very little breast tissue. Yeah.
So let's just say, because I'm just going to go big.
Yeah.
Okay. I think she gave me a date. Let's just use that.
Okay.
April 15th.
Okay.
was the mastectomy one. April 10th was the lumpectomy.
Sure.
Don't even know if that's still available, but whatever. So mastectomy, you said, was really easy.
The mastectomy was, but see that it was different.
Just
I
just
didn't-
that question, Mom. The mastectomy was easy, right?
Yeah, because they didn't do anything else after.
Just
They didn't put any spacer
Expand
in.
Oh,
They just did the mastectomy because I didn't do the reconstruction.
at the same time.
I didn't think about doing reconstruction at that point.
Okay,
But 9
and
months
you-
later,
you did.
I decided I wanted
Okay.
This
reconstruction.
must have been years ago.
35.
35
Okay,
years.
Yeah, so things have changed.
Yeah.
Obviously. Yeah.
So, say that happens on April 15th, right?
Yeah.
6 weeks of recovery.
For the mastectomy, yeah, that's fair.
So
That's generally what we recommend.
Alright.
4 to 6.
So that's, I'm just thinking.
Yeah, puts you into early.
May 15th, so it'll be June 1st.
Sure.
2 weeks left of school. Then, let's just say I want to go, the tummy, whatever.
Yeah.
Because that would be the most invasive,
Correct.
right?
Yeah.
How long would I have to wait from April 15th, the date of my mastectomy, to actually, and I know it all varies. I understand
Minimum of 3 months.
that. Minimum of 3 months.
So at least until mid-July.
And then what's the recovery?
2 months.
How
It's
long?
a little bit of a longer recovery. 2 months.
So I probably wouldn't be able to go back to school when it starts.
Correct. Now, you could, again, if you said, hey, you could keep the expander in for longer, right? If you said, I'm just going to make something up here. If you said, look, I really want to do that flap surgery and I want to do it over winter break, you could do that. So it doesn't have to come out at 3 months. The expander can stay in there theoretically for years if that's desired. But obviously, most people want to, get the show on the road and finish the reconstruction. You've got a little flexibility with your schedule, so it's kind of a
Right.
personal thing
Yeah.
to some degree.
Yeah. Well, I'm just trying to get in as much information as possible that I can see how long I have to be out of work, see all that stuff. Because we don't get,
Now,
once my 6 days are exhausted.
now I hate to make this overly complicated. Let
No,
me let me let me take a look at you. If we are doing nipple sparing, if we're preserving your nipple, we may be able to skip the spacer and go directly to the implant. There are times I have to look at you first and see if that's an option.
So it's a one-shot deal?
One-shot deal doesn't mean you can't do this. In fact, many people will do the direct to implant knowing that they want this, but the implant's a lot more comfortable than the expander. So at least you're saying, okay, I'm treating this as a temporary thing, but it's a whole lot better than having the expander.
Okay.
So
You would be able to tell more about that today or the day of the surgery?
I will have a pretty good sense today,
Okay.
but the final determination, unfortunately, is in the operating room because it depends on how.
Why can't we do mastectomy and reconstruction all in one? Just,
You mean the flap?
yeah, like from beginning to end all in one. Is that just too hard on the body?
Well, when you say reconstruct, I'm saying we kind of are. I mean, that's what I'm proposing essentially.
No, I'm mastectomy and reconstruction all at once.
That's what we're planning.
No, I thought you said
That was
You
just a
put that
space
in,
holder
and then-
instead.
So we may be able to skip the space holder
Okay.
and go right to the implant. So that would be all in one.
Okay, that would be all in one.
And you would have the option of saying, oh, I'd like to do the flap, or hey, I'm actually really good with this. You would figure that out later. You wouldn't have to figure that out now. Does that make sense?
Yeah.
What we can't do is do the mastectomy and the flap surgery all together.
That's what I was.
That
ri-
becomes too long of a
so
surgery.
too long.
Higher complication
Right.
rate.
That's what I figured.
Yeah.
Because somebody sent me a link that, oh, they're doing them all in one now.
We used to do it all in one, and
Yeah.
then we learned there were problems. So now we separate them. And
Okay.
that's us, MD Anderson, Memorial Sloan,
No.
all the big cancer.
Well, you have all the data in
Yeah,
front of you of
exactly.
who did well, who didn't do well.
So when this became popular, people were like, yeah, let's do it all at once. How cool. Not that simple, right?
Okay.
How long would the surgery be?
For a mastectomy?
Mastectomy, whether we're doing expander or implant, is about the same length. It's going to be in the ballpark of about 2 to 2.5 hours. It's the surgical.
That's not too bad.
No.
You don't
And
need
the
a bladder.
lumpectomy?
About the same, 2.5. Because if you're doing the lumpectomy, the lift takes a long time.
That's
a lot
right.
of sewing.
Okay, yep.
Yeah.
Okay, let's check it out.
So let me get you. You need some help changing?
Oh, yeah.
Are you gonna help me?
I got it.
Okay. I'll give you or if you don't want to put on the robe, I mean, I'll completely leave it up to you. But this is at least, let me just prep it for you so it's a little easier.
Why, thank you.
Sure.
I need all the help I can carry. Tap that. So you know that that's playing.
The nipple position at the same time as the nipple.
Okay.
So if we kept the nipple, it would look incredibly bizarre. It would be a really bad idea. It would be sort of stuck on the bottom of the breast and we wouldn't be able to fix it. So it's just not a good idea, long
Okay.
story short. I don't take that lightly, but it really is your ideal option. So then the question becomes, well, if you want to sit more comfortable?
No, I just got to hold my
If you're so, I don't know enough to look anymore. That's kind of the big thing.
Oh, well, if I don't.
I'll take the iPad, Liz.
Yes, sir.
Usually, if we're going to be doing both sides, it's best to do the same thing to both sides for symmetry purposes.
Oh, yeah.
Right?
That's why I wouldn't just do one.
Right. Okay.
I don't understand why people would just do one, because then
Yeah.
there's the chance.
You know, I always bring these things up gently because you never know what people are thinking, honestly. You know, but I think you're thinking about it the right way. You want to do the same thing on both sides.
Right.
To get the best.
So you're
possible
saying
result.
because this one's lower, we can't do what we discussed
Correct.
with the.
So then it's definitely tissue expander, and it would not be a nipple sparing mastectomy. It would be a nipple removing, what we call a skin sparing mastectomy. It's stupid terminology. I'll show you some pictures so you can see where the incisions are, okay?
Mm-hmm.
Hopefully we'll kind of bring some of these concepts to light. So first thing I'll show you, it's a woman before surgery, okay? I'm going to show you after the mastectomy and the expanders have been put in place.
Okay.
She wanted to be smaller than she was to start, so not very big breasts, but you're going to see her without nipples and a little scar going up and down the breast, okay?
Okay.
So that's what she looks like with the expanders in place, filled. The
Okay.
expanders have been filled. So probably about 3 months after surgery, pretty much getting ready for that second surgery. That's where she is now. Okay. The scar is here, going up and down, and then there's a longer incision underneath the breast that you don't really see because it's obviously in the crease of the
Right.
breast. Okay, but if you do a handstand or whatever, you can see a longer scar underneath the breast.
How painful is it to recover from just mastectomy?
Most people tell me it was not as bad as they thought it was going to be.
Okay.
Doesn't mean it's a walk in the park.
No,
but
I know that.
But I think a lot of people anticipate something horrible, and
the reconstruction's worse.
we very rarely do a mastectomy by itself these days. So it's done together. You mean the reconstruction, the second surgery?
Yeah.
The finish? Depending on whether you pick the flap or the implant. The implant's a joke. The implant's really easy. The flap surgery's the big one. Yeah. So if you do the flap surgery, it is a bigger surgery.
It's a bigger surgery, more complications.
Very safe, but definitely more things to know and understand. And it's a very specialized kind of surgery. So I don't do the flap surgery. We have 2 partners who are both excellent in my practice, who I would send you to meet, go over the flap in more detail if that's the pathway you want to go down.
What percentage of women that get reconstruction choose that?
Probably about 30-40%.
Okay.
Yeah, it's probably pretty close.
Pretty high.
It's pretty. Oh yeah, it. What moves the pendulum towards the flap? Younger patients like you, so under 55 generally, because obviously if you do implant, potentially need a lot of surgeries over your lifetime,
Mm-hmm.
right? So what pushes the pendulum towards the implant? Older patient, 75 and up.
I'm not gonna have to get it done yet.
Right, and they're not going to tolerate that that big of a surgery.
Right.
So your youth is sort of, if you want to think of it this way, is sort of the silver lining. You heal faster, you have more options than someone who's older.
Do I have enough tissue? And
I didn't look at your belly,
Okay.
but we can.
Okay.
Just another quick example. Here's another woman before surgery. Some asymmetries, exact same thing we're talking about. But I'm going to show you after expanders, after the expanders were removed, then implants replaced,
Okay.
and after her nipples were tattooed. Okay?
Okay.
So that's after the full shebang. Now, obviously, depends size, shape. It's a lot of personal decisions, right? We go with.
Those are tattooed?
Mhm. So if you run your hand over that, that's
Flat.
completely flat. That is not her nipple. That's a tattoo. That's why I showed this picture, because I think a lot of people don't realize how realistic these can look.
Wow.
Pretty cool, right?
Pretty cool.
These are not done by me. There are two medical artists in Hampton Roads we work with. They do this a ton.
And this, I'm sure this is after the surgery.
After this is the last thing.
And that's also covered.
The nipple tattoo is sometimes a little tricky, and it can cost, at worst, about $800. That's your worst case scenario.
Okay.
Usually, both of them, if you say, look, I really can't afford that, they will work with you, and they will discount the price. So, that needs to be done. We want you to get it taken care of, and so do they. They're good about this kind of thing.
Okay.
Just a couple of examples of flap patients. So obviously now you see the picture includes the tummy area, obviously kind of big pendulous breast to start. That's the flap surgery. So the tummy is very different, and that skin and fat has been used to recreate the breast. Going to be very similar concepts that are redundant, right? You can see the ideal candidate is someone who's got some loose skin there.
Yeah.
From pregnancies, from weight changes, whatever it might be. Right? Same idea. Again, not to get too ahead of ourselves, but just to give you a little sense.
No, I want to know everything,
Yeah.
which would help me make the decision.
If you don't mind, let me just take a quick look at your belly, see if
Yep.
that is a good option for you. Remind me, have you had children?
Yes.
How many have you had?
2.
Okay. And goal cup size is pretty much where you're at now.
This would give me a C.
I'm saying your goal is to be about the same
Yeah.
you are now. And remind me, what's this scar from?
Resection of my colon.
Have a seat. What we would have to do, which is a common thing, is for someone who's had abdominal surgery like that, is we have to do this special kind of CAT scan to make sure that that previous surgery you had didn't injure some of the blood vessels that we need for the skin to survive up here. So we don't know.
I'm never just a normal patient.
So the CAT scan will be our tool in helping us figure that out.
So that would actually have to be done prior.
So we would do that after the inspection, we get your CAT scan, that special CAT scan to assess and help us figure out what our options are.
Okay.
So you won't know if you would be a candidate for the
Now there are other options other than the skin and fat here. Sometimes we take skin and fat from the love handles, sometimes from the upper or lower buttocks, sometimes from the thighs, sometimes from the upper back. So there are lots of different choices this gets.
Right here? No.
Not so much right there,
Okay.
more under the butt or on top of the butt. Yeah.
Okay.
It's based on, we need to find a block of skin and fat that's going to live off a single blood vessel. So it's all about finding where these vessels live, obviously where they're reliably found, and kind of centering a removal of skin and fat based on that blood vessel. Because that blood vessel is cut and then reconnected up here. That's the transplant part.
And what is, wherever you take it from, it's going to heal and just be skinnier or.
It's going to be closed in a straight line wherever we take it from. So there'll be a long scar wherever.
But it won't be
depending
deformed.
on- No, that's
Okay.
right. That's not the goal. Yeah.
Right, okay.
No, but I mean, a scar, if you tell me, well, a scar is a deformity, then okay, then yes. But no, that area.
I have so many scars on my body, so.
So I know I'm giving you a ton to think about here, hopefully not overwhelming you.
What would you tell your wife to do?
think it depends a lot on personality. If you tell me I do not like the idea of the possibility of recurrence, I would do double mastectomy, tissue expanders.
You would do this expander versus the
She's not a
implant?
she's not a candidate for putting the implant in right away because we have to remove the nipple and that tightens the skin.
Oh, I see. I must have missed that part.
No, it's a lot, you know, and I know I'm kind of jumping around a little bit.
I mean, there's a lot of things I would love to keep my breast, but there's a lot of things that scare me on the lumpectomy. Like putting that, what is that called? The thing back in where they put the little pellets in.
Oh, the brachytherapy.
Yeah.
Yeah.
Just to put that in, and I'm not even asleep for that.
Yeah, I mean, look, again, I will be the first to tell you I'm heavily biased. I'm not a fan of radiation because it really, to me, the breast is permanently altered in a very negative way. It's like the breast has been permanently damaged. I don't like that idea because it's very hard to get good cosmetic outcomes, and even if you do, they're going to age very differently. Right now, you're going to have one breast that got radiated, one that didn't. So what's going to happen over the next 10 years? They're going to just look completely different. So you're probably going to need some additional surgeries in the future to try to address that. And it's never going to look great. And you're happy with the size you are. You don't like the idea of being smaller. That's the other piece that I'm not so sure that lumpectomy and radiation is a really great choice for you. If you say to me, I really don't like being the idea of a B cup, lumpectomy is not a great option. It is going to make you smaller. And in addition, it handcuffs our ability. If you say, well, let's maybe we'll put in an implant later. The area having been radiated, the complication rates are higher with implants. So it gets, again, there's so many, this rabbit hole keeps going further and further. But yeah, definitely a lot of concerns there for you, I think, for lumpectomy.
How safe is all this that you're talking about?
Big picture stuff, scary stuff, stroke, death, things like that. Never seen. And I do this kind of surgery 10 to 12 times a month. So for 10 years. The biggest thing we worry about is infection. We've got foreign object right under the skin. Our biggest fear is some bacteria work their way in through the incision. You get an infection that can't be fixed with antibiotics alone. It requires additional surgery. Sometimes even means this expander needs to come out temporarily. Meaning one side gets badly infected, we have to take it out, let everything be flat for a period of time, and then come back to start all over again. So you can still have a reconstruction, but it just lengthens.
How often does that happen?
About 1% of the time.
So you get an infection.
So what I can promise you is I do everything in my power to reduce that risk. There are these modern techniques where we use these dissolvable antibiotic beads, these special washes. In surgery, I won't bore you with all this stuff, but it still can happen even doing everything right.
Right. Well, yeah, you can never.
Yeah.
Everybody has the risk of getting an infection.
The other thing is bleeding, also less than 1%, but some little blood vessel kind of opens up after surgery, and then the breast fills with blood. That usually requires surgery as well. That's very infrequent.
How often, how long would it take? Would that happen like within the first couple of days?
First couple of days, yeah. Also very rare.
Are you in the surgery for the mastectomy? Yes, because you got to put
Put in
those
the expanders.
expanders in.
So Dr. Brown does the surgery.
Mm-hmm.
We're both doing our parts of the surgery. She's doing the mastectomy. I'm placing the expander in there. So we're there together. It's for you it's one surgery.
And then the reconstruction, who does that?
If we're going to do the implant, I would do it. If we're going to think about those flap options, then one of my partners would do that. Because that's all they do.
But that's something we'll come back and talk about later on.
I think we'll get a lot of important information with the expander, right? How much do you like it filled to? How How do you feel with it? How do you feel about it? What kind of look do you like? You know, do you maybe like, hey, you know what, actually I like having a little bit more roundness than I had before. Some people surprise me.
How do you adjust it if it's up against my,
It's got this little valve on it.
right?
So we actually use a magnet that helps us identify where the valve is.
Uh-huh.
And then a little needle goes in and we fill it. You won't even feel it. It's a small needle. You won't even feel it.
Okay.
Really.
So I see the oncologist tomorrow.
Good.
And then,
She will give her points of view.
yeah, I don't even know what I see her for, but, and then my next, do I have to go back and see Dr. Brown, or am I just scheduling with whatever I choose, or?
Definitely gonna, after your oncologist, I'd suggest, if you feel like you're good with your decision, I would suggest reaching out to her and us to let us know. Like if you say, oh, you know what, I decided I want to do a lumpectomy. The sooner you let us know, obviously, just as an act of courtesy to other patients, it helps us kind of schedule things, right? So whenever you decide, let us know. That way we can plan appropriately. And then she may want to see you one more time before surgery.
Okay. Because I was looking into April, because I'm moving, so I want that spring break
Yeah, to move.
to get everything done and then have my surgery. I think they told me that the 15th was open, but that was a week ago. So I'll just have to check.
We'll figure it out. I bet April should be reasonable.
Okay.
So I'm gonna if it's okay with you, just to get the ball rolling and so you don't get thrown into May or June, I'm gonna just tentatively schedule this as you having a double mastectomy with Dr. Brown and with tissue expander reconstruction.
Yep. For right now, unless I change
And then
my
obviously
mind.
that is the among the things we're talking about is the thing that requires the most equipment and things to order. So
Right.
if you switch to lumpectomy, really easy.
Then it's
for us.
easier.
Yeah, exactly. So
Okay.
I'll
So can I put a date?
I'll have Candace is gonna call you probably this week to secure your date.
Okay.
She's my scheduler, Candace.
Okay. She's not here today.
No, she works in another office,
Okay.
so she's mostly by phone. But yeah, so she'll call you.
So I schedule the surgery with you, not Dr. Brown.
She is gonna coordinate between you and Dr. Brown's office. So
Yeah, I heard they're like
Yeah.
BFFs.
But you're probably exactly. But you're probably gonna have to talk to Dr. Brown's scheduler also,
Okay.
because they'll give you all the blood work, prep stuff goes through them.
Okay.
I know it's a lot, so I wish it was easier. Hang on
That's what it is.
Hang on there, my friend. It's gonna be ball in your court on whether you want to see me again, chat through this one more time, or if you want to just let's go for it. The one thing we haven't talked about yet, which I would save for when we get closer, is the recovery. Like specifics about the recovery. There's not a whole lot to talk about, but we talk about it and most people will forget. So it's kind of, I think I would recommend seeing me one more time just to touch on that.
I mean, is it like after the mastectomy, is it like 6 weeks in bed? Or just 6 weeks of no lifting or no doing certain things like that?
You got it.
I heard you go back home the same day.
Yeah, you got it.
Same with reconstruction. Well, it depends on what you get done. That's right.
Implant, yes. Flap, no.
And that recovery time, did you say?
Implant is quick, about less than a week.
Okay.
Flap is 8 weeks, technically 2 months.
Okay. And I can wait and do that down the road and just work with the oh no, because we were talking about having that and
But
then
you're also going to see how you feel with the expanders,
Right.
right? And that you might say, you know what, I'm actually doing great. These don't bother me at all. You can wait as long as you want. We could wait until summer of 27 if you really want.
I'm sorry. When you put the expanders in, does it kind of blow up?
kind of.
We inflate the expander here in the office by using a needle. So it doesn't blow up on its own. It goes in pretty empty, so the breast looks very strange. We start that inflation process 2 weeks after surgery and do it every week until we get to the size that you like.
So in other words, she'll be flat for.
Not completely flat, but the breast will look pretty funny and bizarre the first 2 weeks.
Because I'm sure there'll be a lot more skin then.
Yeah, and when it's empty too, it kind of doesn't have any shape, right? It's gonna
Right.
so the breast will look odd at first.
Right. I'll just keep it covered.
Yeah, you want to, honestly. There's no point in looking because it's gonna change, right? So,
Right. Okay. Yep.
So let me let you change, let you guys go. Let's start the ball rolling. And we'll plan on seeing each other again before surgery.
Can you get the ball rolling even though I don't have the date yet?
That's what we're gonna do is secure your date
Okay.
and so coordinate everything with Dr. Brown's office so we have a locked in time and date for both of us.
Okay. Okay.
All right. Hang in there. Nice to meet you.
Okay, nice to meet you.
too. Come on out whenever you're ready, okay?
Okay, thank you.